adolescents with eating disorders who also have ADHD. Is that what you're saying?
Right. Medication choices. I do feel like I get some result for some of my kids with Stratera for some improvement in attention. But obviously it's not my favorite choice. But with especially with the restrictive kids, I really hesitate to do a stimulant and further suppress appetite. Some of these kids, the shame and secrecy is so much a part of what is going on with them that I don't know about binging. So I, way back a long time ago when I was in residency, I was told to not use Wellbutrin in these kids because of concern of lowering seizure threshold if they are binging. So I'm just curious, what you guys tend to reach for, what you've seen work or not work. Most of these kids are already on SSRIs as part of their eating disorder treatment, right? So hopefully getting some improvement in anxiety from that. But some of that inattention, I think, is because their brains are in eating disorder mode. But this has come up a few times.
Wow.
Past few years, and my wait time to get in to see psychiatry is really long.
Even in Lancaster, you could send them down to Hopkins.
Yeah, I can.
Really long here, Barbara.
What? No.
No, there's huge demand. There's every place has a waiting list. Yeah, there's unfortunately.
Well, good news. Emily's on the call, and Emily is the co-author of a textbook on psychopharm, but I know she's going to have some comments about eating disorders and ADHD first. Right, yeah. Emily?
I think what's tricky is, I think one of the things that you just said was really important, which is that they're very preoccupied and they're, not paying attention. I think because they're thinking about food or weight or what to do, things like that. That's different than the inattention of ADHD. And that I would really think about focusing just on the eating disorder symptoms and let the ADHD go. They may not have ADHD when they're fully, their weight is normal, they are treated for their eating disorder. And I think it's very hard to go after both of those at the same time for a lot of the reasons that you raised. And so if they have ADHD, that'll declare, you'll deal with that later, but I don't think that's going to be the most important thing to treat if they have an active eating disorder. I think, the thinking is if there have any risk of purging or anything that would dysregulate their electrolytes, then Wellbutrin is not an optimal choice, and SSRIs are much safer. But I would worry a lot less about the ADHD while they have an active eating disorder.
What about the kiddos that are well into recovery? Like, I'm thinking specifically about a 19-year-old college sophomore this year. She was discharged from adolescent medicine 5 or 6 years ago. Middle school was really when she was identified with her eating disorder and was in intensive treatment at that time. I met her a couple of years ago, maintained her on her SSRI, and occasionally she'll talk to me about a little bit of disorder, eating disordered thinking kind of popping back in, and use that as our trigger to get back in with her counselor to work with that. Heading off to college in the middle of a pandemic was not an ideal situation. So she uses that as just sort of our trigger, like you need to get back in to be consistently in with your counselor again for a little bit, manage some of that symptomatology. But otherwise, she has been weight stable since I met her several years ago, and kind of in and out of some counseling with her previous counselor, who, usually kind of sees her for, we kind of call it a tune-up. and then, you know, goes back to PRN sessions again. And she feels that she's got her eating disorder. It's a lifelong disorder, but she feels like she's really pretty well controlled. But as we talk more and more, I think because the focus, I think that some of where maybe her early anxiety came was because she probably was an inattentive ADD kid. And moving into middle school, I think that was playing into her academic success, and she sees herself as a highly successful person. And so this kind of spiraled for her. And looking back, I think she would easily meet criteria for an ADHD and attentive type kid early on. But it has really been put aside. And now that she's a sophomore in college, through high school, she definitely struggled some academically. And now that she's in college, she's really noticing these issues coming to the forefront. And we're going to work towards getting her formally diagnosed so she can access some student services around the diagnosis. But she was asking about medication, and I was like, well, I'm not really sure I'm particularly interested in you doing Concerta or anything like that, especially when she's on her own at college and not having, not being in a household where somebody is sort of able to monitor if her food intake is dropping off significantly.
I think these are important things to think through. My own personal thought would be that if she sounds like she's quite insightful and aware of the warning signs and symptoms of her eating disorder, and she is connected to care for that, even if it's intermittent, but that she is open to the idea that that's a lifelong struggle and that there will be need for periodic tune-ups. I would use a stimulant in a patient like that. I might not use a long-acting one. I might think through with her, what are the times, what are the moments? She may not be somebody who needs to take it every day. She may need to take it when there's an extended assignment or she has an extended project or things where she needs more sustained attention and focus. But it might be that taking some regular dexedrine occasionally, and she could keep track and report back and then figure out, how many pills do you give her for what the schedule looks like or things like that, rather than an every morning taking something that's going to work for 12 hours. It sounds like she's pretty motivated and really responsible. The other thought would be that could be done in conjunction with her staying in more active contact with her clinician that works with her around her eating symptoms, so that somebody else is checking, even if it's like every other month or something like that, so that she had an additional set of eyes on her who knows her well.
Yeah. Okay. Thanks. I appreciate that.
Excuse me, I'm letting you in. I had it muted because of the dog. Sorry, go ahead.
Yeah, I agree with what Emily said. If the academics was the main thing and dosing it that way. The thing, I just wanted to comment that this is inattentive ADHD who had eating disorders, and some of those kids have anxiety, and then the part that contributes maybe to and they get indecisive, or they can get into overthinking, ruminating kind of thing that goes into eating disorders. So sometimes the stimulant helps them focus on the thing that they're not sure about.
And then they just go.
Ruminating and uncertainty kind of thing. And so it's something to be thinking about. And if she understood, if she really could, she's that insightful, she could understand that when it focuses on her being indecisive rather than trying to process lots of stuff fast. So it may well be that anxiety is part of her inattentive picture rather than, a garden variety HD that's not inattentive and stuff. So I'd be watching for that and trying to elicit her own thinking about that could happen. You could get more focused in being indecisive.
Yeah, that is a really good point. And that speaks to really needing to drill down about what academically she's struggling with. And, is it that she's not able to attend during an exam, or is it that she's, getting stuck in cyclic thinking and the indecisiveness during an exam, and that feels like inattentiveness, and instead it's really some of those rumination symptoms.
And it may be more anxiety than it
Yeah.
is ADHD.
Yeah.
So I'd like to expand the conversation just a little bit. Welcome, Joanne, and also welcome whoever Jeffrey is. I don't know who the first letter of Jeffrey is, but somebody new on the call. Can we talk about whether Intuna would ever be something that would be helpful in this situation, because it doesn't have the same kind of appetite suppressant treatment. I don't usually use Intuna with older kids. And of course, blood pressure can be a problem. Low blood pressure is what we're talking about here, could be a problem in eating disorders to start with. But Emily, any comments if Melissa really feels as though the ADHD needs something, would you ever consider Intuna?
Yeah, we use Intuna all the time. I think it's a great medicine. I think, it might make her sleepy, and I don't know how she'll feel about being a sleepy college student, depending on her timing when she takes it and, things like that. But it's a great medicine.
She's kind of a homebody college student. She's
all right. So, I mean, if that were something, but again, I think to Ray's point, and, is this really ADHD?
Yeah.
I think is
right.
probably a bigger issue, but I think it could be. I like it as a medicine. We use it a lot. It's much better than clonidine because it's more selective in the receptors it hits, and it doesn't lead to irritability, which clonidine can, and it's not as hard on your blood pressure, particularly if they stop it suddenly.
And doesn't cause the loss of appetite that I think you're worried about with the other stimulants. Like, we don't want her to have a loss of appetite since she's having to force herself to eat in the first place.
Right. I don't think you, Emily, you may have answered this, Emily, and I wasn't, but I was answering my kid. What about Stratera? Do you reach for Stratera much?
Yeah, never.
I
I just don't use it. It does. Stratera was designed to be an antidepressant. It's a tricyclic in structure, and by the way, they noticed maybe it had some mild attention effects.
Right.
And they paid, they got.
That's where the money is. They want where the money is.
Exactly. Yeah.
I don't reach for it. I don't think it works particularly well. And yeah.
Okay. Yeah, I don't use it much because I haven't had great success, but I didn't know if I was missing the boat on that.
No. And that's why I wanted to mention Intuna, because if we're looking for non-appetite suppressing ADHD medicines, that's another possibility. The other thing that maybe we could mention is performance anxiety related to tests. With violin players who have anxiety attacks before they perform, propranolol is something they consider. Now, again, propranolol, slows down your heart rate and can drop your blood pressure and may not be okay with eating disorders either. But Emily, would you comment on propranolol if it turns out that Melissa finds out that this is really test-taking anxiety that she's running into?
So test-taking anxiety is a little bit different than performance anxiety.
True. Well, maybe.
So I'm a huge fan of it for true performance anxiety, as long as people try it out before they hit the stage so they don't pass out on stage. There probably are some people who can use it for test anxiety. The challenge is, all kinds of situations can be true test anxiety, right? For the rest of her life, there's going to be test anxiety of some sort or another. And so I would think about CBT, test anxiety, rather than a medication, if at all possible. So I think there are plenty of, actors and performers who do use propranolol before they walk out on the stage. But I think if we see a kiddo with test anxiety, I'd much prefer they get either their bigger anxiety disorder treated with meds and CBT, or to figure out what else is going on. So I probably wouldn't use it for test anxiety per se.
Now, notice that Emily said CBT. which is cognitive behavioral therapy, not CBD, which I'm going to ask her about next.
Really, no,
Right.
I don't know much about CBD. I just don't know. We don't use it. We don't give it to children. So I just don't know anything about that. I can't answer that one, Barbara.
But she's not a child, and I don't know if it's legal.
Well, I don't know about
Yeah,
using
yeah.
it in those things. I just
Right.
speak
Yeah.
to.
You might, Melissa, ask her about whether she's already self-medicated. Just keep that one in mind.
She is not, because I do have several college students, had several college students that there was a lot of self-medication occurring.
Mhm.
She is not. And I feel like she's honest with me. She's been pretty frank and honest about some other typical college student issues. So I think I would have heard about it
That's
when I
great.
asked.
And you know, one of the things about this case, and Joanne, you came in a little bit late, but not too late on this case, is that Melissa's been following these kids for years. And that's just one of the benefits of being in pediatric care, is that you really have a feeling for somebody by having known them a long time. And I congratulate you on that and the relationship you have with them, because that makes a big difference in and of itself, besides being able to help pick what treatments might be appropriate.
Well, my question, Emily addressed some of my question. I see some kids who come in and they've been placed on Stratera. And for the life of me, I'm thinking, Stratera, they must know something that I don't know. And so my question was going to be, what will be the indication for placing a kid on Stratera instead of placing them on a stimulant? And then my other question, the follow-up, which you also talked about, was Intuna.
Me either. I don't use it.
I don't like it
I don't
either.
even- I think the reason that you don't know is there's some detailed guy you don't know who doesn't come to your office.
Some
perhaps.
pharma detail.
But what happens, it has some effect. It has a smaller effect than the stimulants when you look at it. And they get some belly aches also that I found. But the main reason I think it gets prescribed is it isn't a stimulant.
So you
I
can,
don't want that Ritalin stuff. I don't want that. Oh, okay.
that's what the parents are
That's-
saying.
That's
They've
what-
heard the marketing.
That's what that may happen. So I have not, I tried it at some point and have not found it useful, although there are some individuals who get some benefit. And when I hear about the benefit, I believe it's a smaller benefit than is optimal for them usually. It's like sometimes people get put on a lower dose of stimulant than could actually benefit them. They haven't optimized. So anyhow, those are my thoughts.
Emily, you want to add anything to that? You're muted. You're muted.
I don't use it. I just don't use it. I've been a child psychiatrist for 30 years. I've never found the need. I've never started it. I often, if I do mostly inpatient work, kids come in, I take them off it. I don't think it's a drug that we need to reach for.
No, I agree.
I think it's often used when people aren't sure what's going on. And I think because it feels, well, it's not a stimulant, maybe I'll get some benefit, let's see where we are. I just don't think that it's a helpful drug in my toolkit.
It also takes about 6 weeks before it's at optimal dose. So that makes it more complicated also. And so, you know, the drug reps were talking about how, well, start it up over the summer when it has time to ramp up. Well, you know, we have other medicines that have better effectiveness that don't require that. Joanne, you're wrinkling your forehead. I wonder if you have a comment about this.
Has anyone had any experience with the venlafaxine, which is been introduced as also for ADHD, but not a stimulant? I think it's an SNRI. So I think it was presented to us as an alternative to a stimulant that had a better results, better profile than the Stratera. I tried it once on one child. It didn't do anything for him at all.
That's I have not ever used that. Emily, any comments about that? Joanne, other things you'd like to bring up?
I'm wondering about the difference between like test anxiety and performance anxiety. How do we address that or figure that out?
I mean, test anxiety can have a lot of things. Are they anxious because they didn't study and they're,
Right.
they're anxious about taking the test? Is it a subject matter that they're anxious about the math test, but they're not anxious about the English test? I think it's, how a test is related to their learning and their, I mean, I may be splitting hairs because I think people sometimes use these terms interchangeably, but I think it's for kids that are in school, understanding which tests are they worried about and why are they worried about it? Is it because they have a learning disorder in that subject that's not been identified? They haven't gotten any resources? Is the teacher really hard? Is that the subject that their parent is a professor in and they think they have expectations to do well? Or, there are a million reasons why a particular test may be difficult versus all tests. Performance, I think about as you're walking on a stage. You're the lead in the school play and you get panicky in the backstage, or you're the first violinist in the orchestra, and it's very specifically related to walking out and delivering in that way, in that role of that skill that you have skills in. To me, that's different than test anxiety, which could be, I'm just afraid I'm going to fail this test because I didn't study or I don't understand the material.
And so I think of performance anxiety as being in front of other people. Whereas test anxiety can be, you go into the testing room and nobody sees what you do. You only find out about the result also. I think that's different in that regard too, because there's a social component.
Right.
So I think humiliated in front of people.
But
Yeah, I think it's important to separate out in performance anxiety. Are there other elements of social anxiety that are contributing to it? Because then that deserves treatment as an anxiety disorder, and I wouldn't use a beta blocker. I would use an SSRI because they may have other, they don't want to eat in front of other people. They don't want to talk on the telephone. They don't want to order at the restaurant. That's not performance anxiety, that's social anxiety. So that's a little bit different as well.
There are kids, though, I agree with what Emily said. There are kids, some of them are high achieving kids in everything and do study like crazy and particularly get panicky in all tests. And so I think there is something there. And I agree with the analysis, what it is. Some kids that can be even on the perfectionistic side can make them indecisive about each choice they make and answers they give and things like that. So I think that usually it goes along with general anxiety and with a particular focus on school related achievement stuff.
This is we're still in the Olympics, so let's bring up an Olympic theme for a moment, and that is now the use of sports psychologists for pre-performance Olympic performance, and not just Olympics, but of course other highly demanding sports. The idea of practicing in your mind and recreating in your mind the circumstances. You may have read an article about this recently because it's been out there because of the Olympics, that you'll see people up at the top of the hill and their body, they've got their eyes closed and their bodies are sort of weaving and going through, and they're actually trying to live the course. And the coaching often includes living the course with people cheering and ringing bells or snow flying in your face. In other words, with some of the hazards, being able to imagine the hazards also is part of what sports psychologists are doing to help optimize performance in athletes. And I wonder how that same principle might apply to other kinds of performance.
Well, there is data that says if your body can't tell the difference, your brain can't tell the difference if you're actually doing it or visualizing it. And that's an important reason why that strategy is used, because it's the same experience as far as your brain's concerned. It's like why people use virtual reality, those little goggly things or things like that. So you can do that, I think, around test and other social anxiety things, but you have to understand what the anxiety is about, or it doesn't work. You just make them anxious. So you have to first treat the anxiety and understand what's driving it in terms of, you know, what are they really worried about? You have to do a fear hierarchy, and you have to think about how you're going to gradually do that with somebody who has an anxiety disorder, which is a little different, but yeah.
Yeah.
And people are using virtual reality for PTSD and things like that, although you clearly would want to do that with proper professional assistance, because you don't want to make things worse, right? By putting them in a virtual reality of something that reminds them of their PTSD and sort of sets them off and make them push them backwards in their ability to cope with things. But they're finding that it works to use virtual reality and, like, you know, goggles and the whole thing to actually do some of the situational desensitization, which is part of cognitive behavioral therapy treatments, but not always convenient. So if the thing that you're really afraid of is like small spaces would be easy, a roller coaster or an animal coming at you, that are things that you can't sort of set up to practice desensitizing to, it looks like virtual reality has benefit for that, for the reasons Emily just said. I don't know, are they using any of that at Hopkins, Emily? They're still muted.
Not that they might be, I just don't know.
It might be more adult. It might be more in the adult psychiatry division that they would be.
We're not doing it in kids. Yeah, I don't know about it.
There are some virtual desensitization platforms that people are using that have benefits for desensitization of particular circumstances. The thing about the athletes was a little bit more, and I think Emily started talking about, with kind of you do things out of muscle memory and practice, and then thinking about it makes it worse. Now we're talking about.
Well, actually, thinking about it enough times makes the performance better.
But yes, but if you're doing it in the muscle memory and you're second guessing what you're doing, it's that.
Oh, you're telling me about a study.
I'm talking about some Boston studies of Super Bowl. They have the long snappers. Long snappers are the ones they get hired to do one thing. It's to hike the ball at a long distance for the place kickers or the punters. And they get paid special. They only come in about 4 times in the whole game. And they want them to be they say they shouldn't be smart in that they shouldn't think of anything. They have to just go into the muscle memory because it's a monotonous kind of thing that they have to do each time. And there's a lot to be said for that. For this.
Joanne, do you have any follow-up, or Koya have any follow-up from cases we've talked about here before?
I still had one of my questions that I was gonna, not on people, but on when best to use Intuna as opposed to my to using the methylphenidate, which is my phone. And then just one last question, Journey PM. It's Jornay, Journey, methylphenidate, which they recommend you give in the evening.
Oh, okay, yeah, they were working on producing that. Right.
The one the one you
give at night, right? So it's metabolized so that it doesn't start working until morning, but you don't have to wait for its onset.
It's very interesting because you know what I've always found, kids are doing well with ADHD, and if there's one area that you think, you know, it's going to still be hard, that's getting the kid dressed and to the bus in time, right? Because they don't have their medication, and there's a structure and there's a time limit, and in my experience, the conflicts and anger happen so much around kids who don't transition well in the morning.
And it can set them off for a terrible day at school if their mother's cussing at them
and the parents
because it was so hard to make it through the morning.
So it was that thing, that whole medicine was aimed at getting some effect in the morning. You put some parents, they wake them up, put the pill in their mouth, let them go back to sleep a little bit, and they get up. I don't know if you run into that. All kinds of things that people have tried to deal with that. So it makes me think a little more about how families deal with that. Deal with having structure in the morning, because it requires structure, because you gotta get dressed, you gotta do the series of things.
It's time sensitive.
And time sensitive, and you have kids who particularly have trouble transitioning from one thing to the next. And the parents' expectations are that that's resistance, and it can cause oppositionality. So I think that the important thing is to focus on that, and making it game-like, to get there in time, beat the clock, all kinds of ways that you could do that in a way that speaks to and helps them get a, you can play with that video game all you want. After you're dressed, you've had breakfast, and you're waiting for the bus. That's the time. And so you talk about, which video game do you want to get to watch? So strategies that help you with structure and acknowledge the issue, and that's transition. And in addition, you could give some medicine in the morning, or maybe this one. But
it does make some sense, because it's a problematic time of day.
It's an interesting problem.
Yeah. I don't know if you remember this, Ray, but they actually interviewed us about that, somebody from the drug rep people, because they wanted to know, how do you rate morning problems? By the way, Koye, some of the things I like to do in the morning is, first of all, get up earlier. Somebody's got to get up earlier, right? Go to bed in your clothes can be very helpful. And a granola bar in your backpack, instead of trying to get breakfast in, because that can be a battle. They may not even be hungry. It's not, and if there's no breakfast at school, just having something in their backpack for the bus, instead of having a struggle over eating breakfast. So those are sort of some, and sometimes, of course, keep in mind, did they go to bed in a time where they would get enough sleep? Because if you have a struggle in the morning, one of the possibilities is they were under the covers with their iPad and actually didn't get enough sleep, so they're hard to wake up. So there's a differential diagnosis for that situation also.
Yeah.
But I would not rule out the possibility of Jornay as being helpful.
Yeah.
That's what I would add to that.
But now I think the understanding of that there's a transition, and parents, instead of being come down hard like prison warden approach, to be able to sing songs in the morning. Let's make it, it's time for the breakfast. Da, da, da. And it's a challenge to parenting and to understanding the child's innate difficulty, rather than being oppositional before it gets to be an oppositional pattern.
Right. And makes it unpleasant.
And anger. And I just think right in that's a crucible of parent-child interaction and expectations. Do you use any tools for transitions? Let me tell you what I have in mind. One of them I used to like was a timer, and the timer I liked is one that goes from green to orange to red, and then it goes bing, 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 bing. So it gives them a warning. It's not all at once. They're dealing with the transitions. So that can happen anytime, but the morning is when it all comes to a head because the time constraints.
You can find it by looking up color timer. But I think, Koye, you had a question more about Intuna than I know.
Yes.
I think Intuna is a really helpful either in addition to a stimulant for a youngster who has a response but gets into trouble with side effects on the stimulants, and you need more to manage their ADHD. I think that can be very well tolerated. It also, I think, can help because it is a little bit, can make them a little bit sleepy if bedtime is a challenge. I think it can be helpful in that way as well. And some kids just can't tolerate stimulants because of the side effects. And so it's a terrific alternative. So I think, in teenagers, you can go up to 7 milligrams a day. It's a once a day drug. You can give it at night, and you can give it, I think people can give it twice a day too, but I think you can also use it at HS. And I think a lot of kids tolerate it really well.
So if I give it QHS, do I have to give it in the morning then, or just give it QHS?
A lot of times you can just give it QHS. It has a long half-life, and it can be dosed that way.
It seemed as though those medications, alpha adrenergic medications, were for kids that they used to describe as being reactive, hyperactive, and had trouble habituating. That is, to calming themselves down. And in animal models with rabbits, at least, they in startle responses, so anyhow, there's some idea that maybe the kids who are overreactive, and they used to use it in combination with in addition to a stimulant.
And there are plenty of overreactive kids with ADHD.
Yeah, yeah, and it can be used alone, and some people use it for preschool kids by itself.
Did you have another comment about that, Claudia?
No.
But the efficacy and the is not quite the level of stimulants, and so I think of it as a second line and adjunct.
Do we have to worry about tapering that medicine to come off?
Well, blood pressure, the thing you're thinking about is blood pressure rebound, right?
Right.
The good news about kids is, generally speaking, their blood pressure is not brittle like adults. And so I don't think it's as important. I mean, you could do it because it says something about it in the labeling, but it's probably not that important.
Agree. You're probably, in the younger the kids, you're not going to use that much. So you can cut it in half and then off. Yeah, I think that's fine.
Joanne, any experience with Intuna? Or Jorna or Jornia, whatever.
No, so I've never done the Jornay. I've never written for that, but it was, I guess the hope was that it, be on board first thing in the morning to eliminate some of those battles, but I have not tried it myself. But in Intuna, we do have a bunch of kids on that. I guess sometimes it's tempting, like some kids who really have, I guess it's dysregulation or kind of explosive behavior, and the parents are wanting something, and I'm always, sometimes, I guess it's a hard place to be, to think about, well, should I really put this young child on something or try some things first? But I think some kids, we do use Intuna in that way sometimes.
And guanfacine is also something that's a possibility in some of those situations. Emily, I don't know if you do any like young adults, whether Intuna would be something that would help avoid the complications of having a stimulant in your blood if you are doing sports and that's a concern, or just the possibility of abuse. There's really not a possibility of abuse from Intuna as far as I can tell.
I mean, for a young adult, in theory, they should know they need this before they became a young adult.
Yes.
Not always true. It's not always true. Graduate students sometimes figure out that they've probably had ADHD all along. I can't speak to whether that's, what the rules are in sports. At that level, I just have no idea whether, if you have a letter from your clinician that says you need this, I don't know how that works.
But in terms of abuse potential, I can't think of any abuse potential.
Well, no, but there is data that says kids with ADHD have a higher risk of using substances. But if you treat their ADHD, they have a lower risk of using substances.
Right, I'm saying.
So, I understand, but I think it's important to not just think about stimulants and their abuse risk. For kids with ADHD, if you treat their ADHD, you've already lowered their abusing. Does that mean they're going to sell it at college? Who knows, right? That becomes, you have to know the individual patient. And I think that's, I don't know that you can necessarily say that there's an easy answer, like do it this way. And then, you really have to know the audience and the situation. And
let's see, we've got Dr. Manello and Ms. Jeffrey. Now that you see what we're talking about here, do you have comments or questions you wanted to bring up?
My question was, some of them, once they're on the stimulants, it would unmask the tics. And so
Mhm.
what do you do? Some is so severe that
Mhm.
you contemplate having to take them off of the stimulant,
Mhm. Yes.
and the alternative then becomes the Intuna.
Yeah.
It's
Or
a
what
good
else
cho-
would you
it's a-
recommend at that
it's a
point?
We
good
were
choice,
downing
yeah.
Stratera, but that is a place where sometimes kids get on Stratera in a reasonable way if the ticks are really worse. But what's hard to know, sometimes the ticks get worse on stimulants. Sometimes they get better on stimulants. And the ticks are waxing and waning over time.
Anyway,
And
Right.
it's really hard to know. I wouldn't assume that the stimulant is causing the tics. It can
but sometimes,
dose related, and it can be
Yeah.
it can be a problem.
Mhm.
But it's about remember the data about a 0.5, a small amount of time where it seems to be triggering it. And the other part of that, of course, is that you're talking about and often a syndrome or a triad of tics and ADHD and anxiety, maybe OCD, all those, and the natural history is that ADHD will present first, like when they're 5. And then the tics, generally, the average age is about 7. Could be earlier, but it could be, so that you could be, they did some studies, you could be, they had twins on stimulants and they got tics, but the twin wasn't on stimulants and he got tics about the same. So there is that natural history in the genetic component. So it's not so easy. And I think more times than not, the stimulants are stopped when they could be beneficial. But it's a hard thing, and it's a hard thing to sort out. And so, but one of the possibilities would be Intuna or in that case, Stratera that doesn't cause
yeah,
tics.
but
as far as we
Intuna
know.
was good in a situation like that. And as Emily said, sometimes you can lower the dose of
Not
the
as effective.
stimulant and add Intuna and have a better effect with less tics.
So that's a hard one to sort out.
Does that help a little bit, or did you have more questions about that?
Well, no, that helps.
And then it's somebody, and you see what you think, oh, it's the stimulant that caused it. I didn't actually, that still would have, but then you take a family history and you find out the mother's doesn't have tics, but I remember this mother, they used to call me Blinky, but I found out later, but no, she didn't have tics, but she was blinking so much. And it,
That was her tic,
yeah,
obviously.
that was the tic that she had. So the family history of it, so that there's often more likely a genetic loading than it's just coming because you would never have had it if you didn't take the stimulant.
Well, so in order for our evaluation of the program and to get your CME credits, even if you don't want your CME credits, please email me 1 or 2 things you'll think differently about or do differently as a result of this session. Okay, so it's bhoward@chattis.com. I'll put it in the chat. bhoward@chattis.com, and I need that from you, please. But we haven't talked about we only have 4 minutes left, so we're going to stop. But you might be interested to know about our results from the positive childhood experiences. I think maybe we did talk about it, but we created a questionnaire, 10 items that corresponded to the adverse childhood experiences, bad things that happened when you were growing up. But we felt like we should complement it with one for good things that happened when you were growing up. And it turned out that the good things that happened when you were growing up actually was more powerful in predicting current social determinants of health in the family than the bad things. So these are things about the parent. So maybe we'll talk about that some more next time. It's about ACE and the opposite of ACE. And the positives basically completely attenuated the concurrent adverse experiences. It was really interesting and fits in with our model as pediatricians and hopefully child psychiatrists said, promoting the positive. for kids, because it makes a huge difference.
Okay.
Okay, so we'll let it
Let you
go right now. Thank you very much, everybody. Thank you, especially Emily.
Thank you.
Hope we see you next time. Tell your friends.